नमस्ते बिटिया, हमेशा खुश रहो बिटिया. A very good morning to you all. Myself, Dr. Ravi Jain, Assistant Professor, Department of Practice of Medicine, and Faculty of Homeopathic Science at JAYOTI VIDYAPEETH Women's University. Today, we are going to continue with the previous lecture of Psoriasis 2. Today, we are going to start with the pustular psoriasis. Pustular psoriasis has two varieties, generalized and localized. The generalized form is a rare form, but it is more serious in condition. The onset of generalized pustular psoriasis is usually sudden, with a large number of small sterile pustules that are erupting on the red base. There is pyrexia, which is coinciding with the appearance of new pustules. It requires urgent assessment and hospital admission. This is pustular psoriasis. Localized pustular psoriasis. It primarily affects the palms and soles and the small sterile pustules which lie on a red base and resolve to leave a brown macules or scaling that you have just seen in the previous figure. So there are small sterile pustules which lie on the red base and these resolve to leave the brown macule or scaling. Next we have arthropathies. 5 to 10% of the individuals with psoriasis develops a chronic seronegative inflammatory arthropathy with rheumatoid factor negative inflammatory arthropathy. It takes a number of patterns, that is central as in ankylosing spondylosis, peripheral as in rheumatoid arthritis. Next we come to the psoriatic arthritis. It occurs in about 1 in 1,000 of the general population and in 7% of the patients with psoriasis. Age, it occurs in between 25 to 40 years of age. The clinical features includes the joint pain and swelling. There are different types of oligoarthritis. The first one is the asymmetrical inflammatory oligoarthritis. It affects 40% of the cases and it has a combination of synovitis and adjacent periarticular inflammation in the hands and feet. As the name suggests, oligoarthritis means involving few joints, asymmetrical, that is not affecting both the sides, and it contains inflammation. This is psoriatic arthritis. Next, we come to the symmetrical polyarthritis. It occurs in 25% of the cases with symmetrical involvement of smaller and larger joints in both upper and lower limbs. There is involvement of the distal interphalangeal arthritis, in which we have it is mainly affecting men, and it targets distal interphalangeal joints of the fingers and surrounding periarticular tissues accompanied by the nail dystrophy. Now, what is the management of the psoriatic arthritis? Psoriatic arthritis is managed by non-steroidal anti-inflammatory drugs, intra-articular injections of corticosteroids, and methotrexate. The investigation in cases of psoriasis, this is in general. Biopsy is seldom necessary, and the diagnosis can be made only by looking at it. The throat swabbing for streptococcal infection, especially in case of gut-tape psoriasis. The joint symptoms require formal rheumatological assessment. The general management consists of explanation, reassurance, and instructions to the patient. Now we come to the homeopathic management. In homeopathy, we have lots of medicines which can be given in the cases of psoriasis. The medicines includes arsenic album, arsenic iodatum, graphitis, petroleum sepia, sulfur, calcarea carb, mercurius solubilis, mesothelium, rust oxycodendron, and staphysaria. Now we will discuss them one by one. Arsenic album. In arsenic album, we have itching, burning, swelling, edema, eruptions, papular, dry, rough and scaly skin that is worsened with cold and scratching. Next we have ars iode. Ars iode contains the dry and scaly itching. It is marked exfoliation of the skin in large scales, leaving a raw, exuding surface beneath. Next, we have the graphitis. Graphitis has rough, hard, persistent dryness of portions of the skin, the eruptions oozing out a sticky exudation. In petroleum, we have dry skin with constricted, very sensitive, rough and cracked leathery skin with burning and itching that is worse in winters. Next, we come to sepia. Sepia has herpes circinatus in the isolated spots. There is itching that is not relieved by scratching. It is worse in the bends of elbows and knees. The sweat on the feet. Next one is sulfur. Sulfur contains the dry, scaly and unhealthy skin. There is itching and burning, which is worse by scratching and washing. There is excoriation, especially in the folds, pruritus, especially from the warmth in the evening. Itching recurs in the springtime and in the damp weather. Next, we have calcarea carb. Calcarea carb has unhealthy, readily ulcerating skin. There are arthritic nodocytes and swelling in the joints. In mesothelium, we have intolerable itching that is worse in the bed and is surrounded by vesicles and shining fiercely red areola. There are thick scabs under the purulent matter exudes. There are long bones, inflamed and swollen. Next, we have Merck's salt. Merck's salt has the vesicular and pustular eruptions with itching worse from the warmth of bed. There is yellowish brownish crust with considerable suppuration, constantly moist skin. Next, we come to rustox. Rustox has red skin which is swollen with intense itching. There is burning eczematous eruptions with tendency to scale formation. At the end, we come to staphysagria. Staphysagria has the eczema of the head, ears, face, and body. There are thick scabs, dry and itch violently. Scratching changes its location of itching, and there is inflammation of the phalanges, arthritic nose. So this was all about psoriasis. In the next lecture, we are going to study about lichen planus. This session was powered by Digital Version 2.0 JAYOTI VIDYAPEETH Women's University. I hope you are satisfied with my digital session. If you have any problem or any query, please mention it in the comment box and I'll try to resolve it. So this was all for today. We will be meeting in the next lecture with lichen planus. Thank you very much. This was all for today and I hope you have understood this thing. So let's meet in the next lecture tomorrow.